We'll go ahead and introduce our next speaker. We have a speaker here, Dr. Bergstrom, who's been with us a couple of years now. You might recognize her face. Dr. Bergstrom is a board-certified dermatologist at UW Medical Center's Roosevelt Dermatology Clinic, has been named one of Seattle Magazine's top doctors. In addition to her academic and teaching expertise, she also has clinical expertise in skin cancer detection, psoriasis, acne, skin cancer removal, cosmetic dermatology, etc. All of the dermatological things you could ask for. Just a quick reminder for any questions that come up during this, during all the talks today, you can just click on the session in the app and then you can do a live Q&A. That way you can type the questions in there. We also will be handing out note cards here if you want to write your questions in, and then please just pass it back to your left and we'll collect those and try to compile them for the Q&A at the end of this session. Okay, thanks. Thanks, Dr.
Thank you so much. It was really fun to hear about hormonal treatments because we use them all the time in acne. So it's a great parallel. Dr. Kendra Bergstrom, I'm at the UW Roosevelt Clinic, and I know we're quite busy, but we're working on our access. I hope as we send more docs, we can help you. And in the meantime, I'd love to give you some pearls so that you can get started on your treatment journey for these patients. I'm going to highlight today rashes, which are both the thing we love and hate the most in dermatology. And we don't always get them right either, but I'd love to give you some structure on how to get started. And I'm going to organize this based on the location on the body. We'll touch on treatment, we'll touch on other clues, and we're also welcome to ask questions. You'll see in dermatology is off-label, and that's just the nature of being a small specialty. And then these are all images on Visual DX if you are wanting to gaze at them longer. So jumping right in, here we see a person comes in with a rash on the fingers. We look closer, we see water bubbles grouped. They're kind of on the edge between the top and the bottom of the hand. They might be itchy, they might pop. People might say, I have pus bumps. They might have started washing their hands more or just life. You look closer and you see, hey, these are also on feet. And they can be confused for pustules, but they're really drying water bubbles. And these are called dyshydrotic eczema. This is an old name when we thought it was abnormal sweating. It is not. It's eczema, skin barrier dysfunction, but it's a really common adult form. Some people will have the allergic triad, eczema, allergies, hay fever, and a lot of people also have wet work issues, new baby, new hobby, cooking a lot. We treat it with emollients because the barrier and topical steroids. My here is this is some thick skin, and we need kind of the strongest topical steroids. So if someone started a hydrocortisone 1%, that's fine, but we want to kick it up to clobetasol, furosemide, betamethasone, triamcinolone, and that's really what's going to help shut this thing down. Of course, we can see a lot of things on our hands. This person may have an acute process, which is actually, instead of being itchy, is quite painful. We look closer, we see a solitary finger, nerves involved, and again, we see these water bubbles. I'd say these are a little more deeply seated. They're quite red on the outside, and they might be tender to any sort of like pressing pustules. This is herpetic Whitlow. Whitlow is a word for swollen fingers, and it's herpetic, often HSV1 and 2, more common in people like dentists. You can see it on the shoulder in someone who's a wrestler, and it's usually skin exposure. This finger is treated just the way any other HSV treatment is done, but the finger itself is quite contagious, filled with virus, so we want to keep it covered while it heals. It can return, though happily it's not as common as, say, HSV of the lips. This person has an issue on the hands, and we look and we see this looks a little more chronic, swollen, cracked, thickened, and we look at their palms, which actually look quite nice. We look at their nails, not involved, and which seems to extend outside of the hand to the wrist. That's a clue to me for something touching, and this is usually contact dermatitis. And when I see it go to the wrist, I think a lot about gloves. Fortunately, nitrile, there's so many different types, polypropylene, vinyl, that people can swap out. And if they really have trouble, I tease them that they need to delegate at home and have someone else clean. They take that well, usually. We can do a skin patch testing, but usually just switching gloves is great if someone has an occupational exposure that they can't change. This person's itchy as well, and they come in noticing the tops of the hands. It might also be on the feet. We might also see it on the belly buttons or the folds. We look closer. There are no blisters here. This is quite superficial. We do see cracks and scales, and they extend, they sort of snuggle into the warm folds of the hands. What's happening here? When we look really closely, we can see this sneaky thing, its little tunnel and its eggs and feces left behind. This is in fact scabies. I tease my patients, I say the ick factor is very high, but it's also very treatable. Topical permethrin, 5% sulfur for pregnancy, or ivermectin. This is one of the times I do prescribe it because the average person I find has the thought of having scabies to be very stressful. Airplanes, congregate settings, staying in a hostel while I traveled to Europe, just bad luck. It's more common than we'd like. The only thing I can tell people is they'll never see it again. And if you have a microscope, you can put it under just the plain immersion oil. I take a 15 blade, just scrape the tunnel, and you can really show off. I feel like a cat who's murdered a bird because I want to show my patients. I'm like, do you want to see your mite? And they are like, yeah, I do not want to see my mite. That sounds terrible. So, but if you really want to have a little party trick with a microscope, pure enough. Okay, so this person has, this is our scabies. This person has a hand rash too, and they might say they have a hand rash. They might also say they have a nail problem. And on the fingernails, we call this maybe a ram's horn. It is big. This did not happen last week. This is a chronic issue. Closely, we can see that the eruption includes the proximal nail folds. It's on all 10 fingers, and probably would see it on the toes as well. Someone might say, I need an antifungal, I need to treat this, but we use our powers of deduction to say maybe these are related. And this can be hand and foot psoriasis. We call it salmon colored, bright pink, hypokeratotic, not usually bloody. And the nails can have fungus, but psoriatic nails is also present, 20 to 30% of people. Having psoriatic nails is associated with early onset psoriasis and a little more likely to have psoriatic arthritis. So when I see these claw-like nails, I'm going to also ask, hey, do you get stiff in the morning? And see what happens. Everyone says they get stiff, so I try to parse it out. First thing in the morning, no symmetrical, lasts a while. That's the extent of my rheumatology, but I try. This one cheated ahead, but I had a case where a patient came in and says, hey, I have psoriasis, and now it's showing up on my hands. Can I have that steroid injection? And I said, wait a minute, this is kind of different. I see these spots, they're not maybe as scaly as those fingers. They're maybe pink to brown. People use the word ham color in the textbooks, which is kind of strange. I'm not really into ham. If you look at the feet, you may also see this. In this exact situation, the person said, yeah, I did go to Palm Desert for the so I took my prep and I should be really healthy, but what it doesn't cover is the secondary syphilis. So an RPI will say it's a positive. I am penicillin. This is the only time I use that. And then the thing that I also remember is once they've had this diagnosis, their RPI is always going to be positive. So we're going to spin off into the VRDL for further diagnosis about getting another exposure. I often talk to ID because there's all sorts of guidelines about how that I am penicillin 1 shot versus 3, and I always appreciate their health. So out of hands. To another place, we're talking about scalp. This is a person in their middle years, and they might say, hey, I have dandruff. They might say, hey, I have flaky snow on my shoulders and it looks bad. And we look closer and we say, is it itchy? Not so much. Again, not raw, shiny. Ooh, here's around the ear. Maybe sneaking into the ear. Beyond the ear canal, they'd say, I have earwax. And this is, of course, psoriasis. Not contagious, not dangerous, but pretty common. About 3 in 100 people will have it. Not everyone knows, not everyone treats it, but I try to parse apart. I think the key thing I find that people want to know is this contagious? Is this dangerous? And I think the corollary is where I give it to my children. And I think because it's rare enough that it's certainly not a one-to-one. There seems to be a genetic predisposition, immune genes, plus something wakes it up. Trauma, illness, group strep in kids. And I'd love to be able to tell someone what that is. But for this person, we just want to keep them comfortable. So treatment, fortunately, they are a ton, and we dermatologists love topicals. Steroids, vitamin D, calcineurin inhibitors. There's new topical phosphodiesterase inhibitors. There's new topical JAK inhibitors, which are only $2,000 a tube. And you can imagine how often I do not go for that one. And as I tease my patients, the ones you see on TV, they are usually the IL-17 and IL-23 inhibitors, which are lovely, but you wouldn't necessarily treat this person with this level of skin disease unless they were really bothered. Like 23-year-old single guy, worried maybe, other people not so much. So when I see that scalp and we see those fingers, where else are we going to look? We're going to look at the nails. This is little pits and they also can have, we call them raindrops, oil spots, ridges. You can imagine this gets confused for fungus all the time. I can trim it for microscope PAS, like it doesn't like path report. I can trim it for a fungal culture, though as you probably remember, that takes like 6 weeks. And reassure them, nope, this is just your psoriasis. People can have both. Other places, hands and feet. Looks a little different, right? And just because our hands and feet are thick, it's always thick and shiny. This could be eczema as well. And it's confusing to clinically, it's confusing under the microscope. And so you can't go wrong with the topical steroids to start. Elbows and knees, kind of the classic, we call it vulgaris, also the tailbone, and then finally this inverse pattern, armpits, tailbone, and you can imagine folks in the genitals get very worried. Is this an STD? In fact, it's not. And either the steroids or the non-steroids can put it at bay quite nicely. As you can imagine, I really like to swab this because group B strep likes to hide in here. And it's just a really nice, easy thing to treat in addition to just using steroids. So we're going to talk more about scalps. I think the blessing and the curse of skin is everyone can see it. So they will tell you about any problem they have. And this person might say, hey, I'm noticing light flaky spots. I'm noticing that I can see kind of shiny scalp that looks different. It may or may not itch. This one isn't spreading beyond the hairline. And this is simply seborrheic dermatitis. I tell people this is the medical word for dandruff, a little simplified, but it works. And again, more common in winter, more common over age 50, more common in cloudy climates. Like, hey, I moved here from Texas or from Florida or from India. And finally, it's more common in neurologic disease. So people who have, say, a new Parkinson's diagnosis sometimes can really watch this take off. And it's not the best to see, but I can reassure patients that it's not lack of caregiving, it's just part of the process. This person might have a different story. And as you can see, it's a little more acute. We might part the scalp and we see, whoa, there are these spots that are itchy, but they're bloody. The person might say, I have scabs, I have pimples, I have sores. And we look closely and they're scattered. The skin is quite healthy. They're both bloody and crusty. And you can see how the hair follicles are about to get attacked and destroyed in a way that could lead to permanent hair loss. So this is what we call prurigo nodularis, and that's just a word for itchy scratching cycle. Where does it start? Maybe folliculitis, maybe other things. This is another one I love to swab. Marissa can hop in here. And the number one challenge I find is getting people into a routine where they don't touch their head. I have a dream of an invisible cone put over, and I haven't figured out how to get that into it. So what I tell people on set is I say, please, I'd like you to touch your skin twice a day, once in the morning, once at night with clean hands. So my hope is I give them permission to have any time to touch their skin, but it's not while driving, things like that. I find fingernails are really powerful, and even in gentlemen or people with short nails, they can still cause a lot of damage. So this person probably has a more chronic process, and we can see that because look, their skin is kind of hyperpigmented, hypopigmented, and a little bit gray. This didn't happen overnight. We can see that the follicles here are replaced by little plugs. There's multiple spots, and the person probably has essentially patches of alopecia. But it's not alopecia alone. This isn't just hair loss, it's hair loss and a rash. The rash is only where the hair loss is, head and neck. This is what we call other direction here, chronic cutaneous or discoid lupus. It loves the head and neck. It leaves scars. The silver lining, about 90% of these people do not have systemic lupus. So when they hear the word lupus, obviously their blood pressure goes up. Only about 10% have positive ANA. We'll do review of symptoms to be sure. There were some interesting studies where they took serum of military folks and kind of watched what their serum ANAs happened before and after they got diagnosed with this discoid lupus. And it turns out people who have more spots, more than 10, more on the head and neck and off of the body are going to have worse issues with systemic lupus. These people generally treat locally just so they don't have bald spots and it looks well. This person has a different history, maybe, and you might hear them say, my scalp hurts. It might hurt all the time. They might say, oh, I just fluffed my hair to one side, which was usually nothing, and now my whole scalp is painful. And we look and we see, wait, what's happening here? This is subtle. What I notice is our healthy scalp is kind of this white color, and here's this pink surrounding the follicles. And look, the follicles have these little white tufts on them, and that means the immune system's attacking the hairs. This is a process we call lichen planopilaris. So lichen planus of the mouth, lichen planus of the skin, lichen planus of the genitals, and here it is also in the scalp. This is also a trichologic emergency. So it's a hair emergency in terms of risk of baldness. Perception on what type of emergency that is, but I want to highlight that's why we're a little more aggressive. And here we have a kind of an emerging disease that only started appearing in about 1996. Obviously chronic, and what people notice is all in this crown, their hairline is receding. It started here, it goes back a centimeter, 2 centimeters. They lose their sideburns, they lose the side of their head and even the back. Their skin feels smooth, and there's almost no view of where those hairs were. It can move a little bit of brown color behind, and we say, wait, what's happening here? If we biopsy this, it'll look just like the lichen planopilaris, but it's a new entity called frontal fibrosing alopecia. FFFA, just because we like a good acronym. This appears in women in their 60s often, though different people, and this is really distressing to folks. So we're aggressive. Doxycycline, hydroxychloroquine, minoxidil, as was discussed earlier, finasteride. And it showed up in the 90s in Australia, and now it's showing up in the rest of the world about 5-10 years later. So there's hypotheses. Is this certain sunscreens? What's happening here? I hope we have more to the story, and I'll see people, like including one of my neighbors, and be like, oh, you had that thing. And it's frustrating because it's not fun to have a thing that someone can see across the room, right? Treatable mostly, but when it gets to permanent scarring, we just don't have that interruption. So this person's younger, and they may come in and say, hey, I have scars. They might say, I have hair loss. They might say, I have bumps. And they might say, I have pustules. And in fact, they have all of them. Maybe they just joined the service and have a new haircut that they're required to maintain. Maybe they'd like a shaved haircut their whole life, but they often have curly hairs, and these hairs dive back in and get the $1 million inflammatory response that we call acne keloidalis nuchae. Limited to the neck, how nice. Acne is the name of it, but it's really a folliculitis. There's no blackheads here. And then the keloidalis is leaving the scars behind, which are both visually disturbing and hard to cover with your hair. If someone's in the service, we can actually write hair permissions to have people let their hair grow a little longer, which is such an elegant treatment. However, it's hard to, like a lot of these things, the earlier we get them, the better. Here's some treatment pros that I think are just helpful for scalps. I find especially with scalps, people hate the idea of putting a cream or an ointment. You're squishing something slimy on your head. So I love a shampoo because I can tell them I'm not giving them a new job. I'm just switching your assignments. My top two favorites are here, ketoconazole and cycloperox, and truthfully, it's because they don't smell, and people will probably use them. This one, selenium, is just a prescription strength of Selsun Blue. Sounds great, right? One of my 70-year-olds wrote the word vile on it and gave it back to me, and I have been haunted by that ever since and try to avoid the zinc, over the counter, the zinc is the Head and Shoulders, Easy Tar. The Neutrogena T-Gel has been discontinued, but Denerex MG217, if you just Google tar shampoo, it's always a cold tar, 2% easy. And then if people like a natural touch, I point up the street on Roosevelt, there's a Trader Joe's, and they have a tea tree tingle. Tea tree, 5 to 12% is probably antibacterial and a little anti-yeast. The peppermint's just for a nice smell. And they stay on the head. The medicines only work when they're on, shampoos only work when they're on the head. So I say, don't use it every day. Pick 1 or 2 days a week, suds it up, then brush your teeth. So floss, do something else, and then rinse it off. And I hope they'll buy into that. Sometimes one of those lose their zip and rotate through, but not everyone shampoos every day. And if you have a complex style or you get a blowout once a week, you're not necessarily going to use that shampoo as often as we'd like. This is where we use other tricks, solutions, bottle, eye drop, shape it up, drop, drop, drop. There's a few different strengths. There's a foam, kind of like the mousse from the 80s. Psht, dab, 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 to go. Shouldn't mess your hairstyle. Two different strengths in there. And there's this fluocinolone oil. It's literally like, it is a deep, I don't know why they ever did this, but they took peanut oil, took off the peanuts, and they put it in this oil. So the oil is absolutely soluble, massage it on the head. It comes with a shower cap. You can just wear it, sleep it, walk off the next day. But if you're using a scalp wear, you can rotate this one in the mix. Over the counter, Scalpicin has a hydrocortisone and menthol that's pretty easy. And I mention this because I just have had very little success on selling people on the other topicals. Finally, the new emerging question I get is, what about that Nutrafol? I see ads on TV, on my social media. So I just want to weigh in because you may get this as well. These people are marketing very well. I mean, we rigorously test. It's backed by science, medical grade. People are happy. Works for everybody. What's not to like? My personal pet peeve is just that it's about $6 a day, which seems like a lot. And you're wondering, well, what am I getting for this? And the over the counters, kind of the most common you'll see, are going to have protein, collagen, fish, seafood. There's a vegan collagen, which I Googled was actually just synthetically made by bacteria. Fine. They always have biotin, which is supposed to be good for hair strength. The problem is, as we know, that streptavidin biotin what sort of reaction is used in our TSH testing and some other lab tests. So we have to have people stop, or else they'll artificially look better or worse than what's really going on. And that's another issue for hair. They add a little vitamin C and zinc because why not? Zinc can be helpful for dry scalp. And then they all have their secret sauce. Nutrafol has saw palmetto, which you may have remembered as being marketed as a BPH herb, and I think it works equally softly as a gentle anti-androgen. Viviscal has cartilage from sharks, which I actually find quite sad because I think a lot of sharks are not doing well as far as being endangered. And then there's some others. It's a sad thing. And then there's some with omega-3s and medicinal yeast, which does not have a definition. The ones that you get, there's some over-the-counter, or sorry, some prescription like telehealth skin services that offer acne and hair loss, and they probably do erectile dysfunction for all I know. But they put topical minoxidil, spironolactone, and these cataracts, prostaglandin blockers, latanoprost and bimatoprost, are FDA approved for thicker eyelashes, so why not fluff it all over your head? So I tell people if it doesn't irritate you, if the budget is working for you, it's not unreasonable to try. But I say to them, and I have a little dot phrase, why don't you try and get these things whatever way works for you? I'm hoping this marketing goes away. I've been waiting for a while. So moving on from scalp, another thing, how about a single spot, single new rash? This person might be in their middle, feeling healthy, one rash, and it's starting to grow and it's starting to expand centrifugally. It might be a little itchy. It looks weird before. What's going on here? This is probably tinea corporis. KOH positive, if you check it, you can also scrape those the floats and send them to the lab and they'll do a KOH for us. And people will always say, where did I get this? So where does it come from? I tell them other people, martial arts kiddos, barefoot at the airport. I've seen people get it from bar the yoga mat. They got a circle on their face. That was a tough bit of news. But basically touching things. Pets, I cuddled a cute kitten that was trying to be adopted out of the supermarket and the soil. So how to treat it? Obviously, we all know topical azoles, terbinafine. The Cochrane studies show that all of the topicals tend to work equally well, and the factor is actually whether people use them. So I tell them pick the one that works for you: gel, spray, cream. We really try to avoid steroids because steroids hide the fungus and let it take off. If you happen to put steroids on a circle and it becomes a giant circle, that actually is a great clue for fungus. And dermatologists do that also, don't get me wrong. So just to highlight a couple spots that we see, again, we see the scaling round over, again with the kittens and puppies, and certainly that's another view of our tinea. This person's younger, probably, otherwise healthy. It might be spring or fall. And I just saw last week. They say, hey, I have a circle with a peel. This must be ringworm. Totally logical. But wait, other things are kind of popping up around here. And this is on the belly. We don't usually get a lot of exposure on the trunk. And sure enough, this is pityriasis rosea, self-limited once or twice in our life, spring, fall, young people. And that person might come back a little while later and might say, hey, let's just see how you're doing. And now they look like this. Here's our friend and has a bunch of other friends. Classically, they kind of make a Christmas tree distribution. They're mostly on the trunk, which is nice because they don't have to see it on their face. I find young people really are bothered by this. We say it's self-limited, but it's 4 months, 16 weeks. So if this is the beginning of summer, this can be a lot for someone to hear. In contrast to psoriasis, to our secondary syphilis, their hands and feet are going to be absolutely clear. So what to treat it with? We can use topical steroids, antihistamine, UV light therapy. There's some really soft evidence for acyclovir. This is HHV 6 or 7, and for erythromycin. So I might pull that out if someone's really distressed. And again, this is the later on thing. This eruption might show up but not have any symptoms at all. And we look and say, it's very smooth. If we were to run our finger across it, it would feel a little thickened. And then we also look, is there any scale? I would say no, there's not. We might see one or two on the elbows. We might see it on the knees, the upper arms, usually a young, healthy person, no other medical issues. And this is that granuloma annulare. About 5% of these folks do have diabetes, but I think that's not terribly different than people walking around. The thing I can tell them, self-limited, very healthy. The downside is, again, all of the treatments are generally off-label and watching and waiting is just fine. So this person might be someone in their 50s and beyond. It might be wintertime, and they might say, I have this itchy rash. It's on my feet, and it's also on my shins. Anywhere else? No. What did you do when you saw it? I itched it some more. Just it's itchy. Or I put, rubbing alcohol and Dial's soap on my super mitten. Anyway, so this is what we call nummular dermatitis, nummular eczema, and it's essentially nummular is coin shaped. So that just tells us the shape. But it really is common to come out of sort of a dry skin barrier problem. And so a lot of people in their middle years in the winter, they were in Colorado when it was dry. They started to get a hot tub and sit in it. Things that increase their dry skin will make this show up. And we can treat it beautifully, but I have to kind of convince people that we want to do less scrubbing, less soap, quicker shower, instead of more scrub stuff off. Now this rash is a little less common, but we're looking here, we see, hey, this thing is red and maybe almost purple. It has, I would say, kind of a targetoid shape, like a Target logo. They might have had some cold sores. They might be taking some NSAIDs for a new process. They might have another illness that we're just seeing, and this is part of what we call erythema multiforme. Not at all dangerous, but very bothersome, and we get nervous if it could be generalized. We want to remove the trigger when we can. So those are some spots. Finally, I see I just have 5 more minutes, so I'm going to do one last rash on the face, and I won't torment you with any other after that. Okay, this person is very healthy, and they say, hey, I have a rash on my face. Bumpy, we see little dark marks left behind, and look, it completely spares the lips. It's not in the nose, though it's around. And then we might look closer and say, hey, you have these same little bumps on the malar cheeks. This is perioral dermatitis, and it's a really common flavor of rosacea. And I want to call it out because people often think it's acne. They break out the acne treatments, the Retin-A, the benzoyl peroxide, they blast it, and their skin feels worse. So instead of being rosacea, we know it wakes up in our middle years, it's chronic. It has about 15 treatments, and I tease my patients, I say, if there's 15 treatments, it means that none of them worked that well. And we go through the list. But again, is it contagious? No. Is it dangerous? No. It also goes along with sensitive skin. So I sometimes feel frustrated. People get marketed that they believe they need a 6-step cleansing program or 13 steps. So they need a toner to take the oil off and a new serum to put on. That is a real setup for this perioral dermatitis. So I really try to gently reassure people that more is not better. And I don't want them to feel like marketing should tell them to spend both hundreds of dollars and buy irritating products. So rosacea can have a lot of looks, and I just wanted to highlight. This is that papulopustular. This person would say, I have acne, but when we look closer, no blackheads, no whiteheads. And they're a different age, and we want to treat that with systemics. They're deep. Perioral dermatitis, again, those little bumps, but sparing lips, sparing nose. There's another flavor of perioral dermatitis that can look more like eczema, but it's just focused down here. These people say, am I reacting to my pillowcases or my products? But we know if they would go through the whole cheek, right? It would continue to the ear, to the jawline. So I can say to them, don't worry, don't throw away all your stuff yet, but we're going to calm this down. CPAP, you can imagine, is something that can make this worse, but I think if it was truly CPAP, we'd see a strip along the line where it attacks. So I don't think it's totally the problem. Rhinophyma is a rare but kind of devastating type of rosacea, more common in men. And I want to call it simply because there are these amazing surgical approaches, essentially cutting the extra nose, and people look really well and they look better. Like a lot of visible diseases, there's a lot of associations, alcohol use, I don't know, uncleanliness, something that are very negative about this type of nose rosacea. And then another sort of mysterious rosacea I'll see is somebody shows up and says, hey, I've never had this. And all of a sudden, I have these pimples. And we look closer, we see these white bumps. They're kind of tall, but all over the cheeks. And this is not a chronic process. We can scratch it and get our minerals, and we can see our friend, the Demodex. It's a eight-legged critter also. It likes eyelids and cheeks. Again, I like to show up and no one wants to see it. And it like moves its little legs under the immersion oil, so it's quite satisfying. And yeah, this is okay. But it's the other cool thing is it's quite easy to treat. Unlike these guys, once we kill the Demodex, this person's better. This is one of the few times I use topical ivermectin, and there was a time when I really had to explain why we use it, but it's actually 1% FDA cleared to treat rosacea. If someone was really trying to keep it simple, this is where the 5 and 10% sulfur come in too. So how do we treat rosacea? Like I said, what do I use? Metronidazole, azelaic, sulfur, and I just told you ivermectin. And so sometimes we mix these up. If people are in a hurry, if they're like, this is crazy, I have a wedding, I'm very face forward, pulsing the oral doxycycline, the whole tetracycline family probably works anti-inflammatory effects, blocking these matrix metalloproteinases. It probably doesn't kill bacteria, but it sure does help with swelling. Accutane is really only good for the cystic part. And this is just a media person who had perioral dermatitis, used a steroid, got crazy, and then had to go back to oral doxycycline to get better. So again, no thank you, steroids. So faces, we see, of course, this would say bright red patches, sparing nasolabial, more on the bridge of the nose, maybe a little on the chin, no pustules, no scaling. This is that malar rash of systemic lupus. This person does need an ANA. They do need blood tests. They do need a good review of symptoms. This person might say, this is chronic and I have this rash, but it also leaves these dark marks. It's on the temples, on the forehead, and I just hate the color that it looks. I hate the red, but I particularly hate the brown. This is a process called lichen planus pigmentosus. And this is a process that's a little more common in places like India. I have patients who come from there and they just were immediately diagnosed. It takes us dermatologists a little longer, but I really love to be aggressive with this so they don't have the dark marks. This person maybe had a rash and was on vacation. Maybe they were in Mexico or maybe some other country, and they went to the pharmacy and they were given a super potent topical steroid, clobetasol with lemon, something like this. And they put it on and the rash got better. And they were like, I got this. And then they maybe kept using it. And then their steroid rosacea, their steroid acne came as a second wave. And these folks might also need the doxycycline. This person has a different eruption. I'd say it's kind of pink and flat. It has a little bit of an edge. It is more on the nasolabial folds, on the cheeks, on the chin. This person might have had a neurologic diagnosis. They might have had HIV or been suppressed. They might just have moved to a cloudy place. And this is the face version of that seborrheic dermatitis. I tell people dandruff of the face just to give them like a way to get their head around it. And depending on what they prefer, this is also a great place for those prescription shampoos. Instead of a face wash, use that shampoo. Creams are great, but my compliance rate for gentlemen is kind of not where I'd like it to be. So I try to find the right thing. So this person has a solitary mucolateral spot, and it's got these little bumps through here, pustules. It's only on one side. It just showed up, and they put some steroids. It got better and it came back. And this is the same steroid version. This is the tinea. We call it Milwaukee's granuloma or tinea incognito, and it's tinea that's been hidden by the steroid and it dives down into the follicles and has a big party. So if you wanted to scrape this for a KOH, it should be full of hyphae, but this is one we like to treat with tablets just because it can be a long time to get down to those follicles. And this person might be a little older and they might not be as mobile. They might have a difficult time cooking food. They might be also have absorption issues. Maybe they have inflammatory bowel disease, short gut, things like this. And we look and we see this raw patches that affect the angles of the mouth, the chin. If we looked in the genitals, it's there too. And this is acrodermatitis enteropathica. I mostly do adult dermatology. This is usually acquired and it's zinc deficiency. Lots of micronutrients can look like this. The classic story is someone just stays at home and has toast and tea for their diet. The nice thing is zinc lozenges, there's like a zinc gluconate, it's a cough drop, is pretty easy sell, I find, to dissolve that and bring your zinc back up. But I think obviously the ultimate is nutrition in general. So it for faces, I'm going to just hop into groin and then we'll stop, I promise. Okay, sorry. This is the point I just mentioned. I'll see some patients that are hesitant to see me, and they'll come with a real simple issue, a mole, pimple, and then I'll say, "Do you have anything else to ask?" And then they'll say, "Well," and they look down. And the visit was all about the groin, and they were uncomfortable to bring it up. So I just want to say, I try my best to make time for it and say, "We see this all day, no problem," but it just happens. This person has pimples in the groin. I have some hairs are missing. There's some blackheads. This looked like they were pretty mad. This is that hidradenitis suppurativa. Hidden, but very distressing, very uncomfortable. The definition is more than 6 months of boils without a positive culture. So this isn't staph or strep or gram-negative folliculitis. This is truly inflammation. It's painful and disabling. People miss a ton of work. They can't wear their work uniforms. And we try to, like a lot of these things, we try to get it early. Severe, these tunnels, these are really hard to treat. These folks might need a surgical kind of de-roofing, removing, and we have docs that do that, but wouldn't it be nice not to get to that point? There was nothing approved for this until about 5 years ago. Now we have adalimumab Humira, we have Cosentyx, the IL-17, we have Bimzelx, another IL-17, and we use infliximab infusions when we need. So it's nice to have some choices. Genital eruptions, I'll just go through really fast. This one, shiny, red, no cracks, salmon colored. This is inverse psoriasis. This person is itchy scrotum like the Dickens, almost can't stop scratching, might wake him up at night. We look and we see these sort of flat-topped purple bumps, and this is lichen planus of the genitals. This person has more of a raw area, new onset. They might have taken antibiotics. They might have a new diabetes diagnosis. They might have been in hot weather and not got to a shower. We see little satellite, we call these subcorneal pustules, these little whiteheads. This is, of course, Candida. This person has a slow onset, again with this arching ring. It's probably moving outward. It might be one-sided. No pustules, no areas. And this is, again, just tinea cruris. People who have fungus on their toenails, of course, they put their feet through their underwear and their pants, and they unfortunately bring that fungus on some small level to their genitals. So if someone's quite motivated, I suggest they put their socks on first. Annoying, but pretty easy. This person might have a big purple fixed area, it might come and go, NSAIDs medications. This is a genital fixed drug eruption, and fixed drug eruption loves genitals. So, of course, that's the thing. And finally, if this person said, "Hey, I have pain when I urinate, I see blood on my toilet paper, I'm uncomfortable, this has been going on maybe into my 60s, we look closer, we see hypopigmentation, we see lack of hairs, there's even a fissure right here. And this is, of course, genital lichen sclerosis. Very treatable, but it's nice to tell people this isn't your imagination, it's not wiping, it's truly a process. Really quick pearls, and then we'll stop. It's always great to check on STD status when people have a genital issue, because that's one of their fears as well. Am I contagious? We want to check elsewhere on the body to give us some context clues. Ask for new medications. Could this be drug eruption? And again, with the steroid and antibiotic use. Then what to do for a real simple workup? What I tend to do is usually culture for staph, strep, or yeast. If you see ulcerations, HSV PCR is a great tool. I ask people to be really careful with their skin, and I'm a nemesis. Oh, sorry. Baby wipes are my nemesis, I'll just say. And I usually have them start a topical steroid ointment. Ointment because it's simple. No preservatives, no parabens, no things like that. And it just sits there. And if I mention skin biopsy, people tend to turn purple and try to like run away. So I say to them, maybe we'll talk about that at the next visit. Just think. And again, treatment pearls. Now I told you you did the highest potency 1 to 2 for the hands. Here, potency 5 to 7. Hydrocortisone, desonide, barrier creams like A&D ointment, baby creams, go for it. Zinc, no problem. Anti-candida coverage, if we're worried about that. Some people have a great response to steroids, like a steroid psoriasis patient. I got this. And then after they stop within 2 weeks, it's back. They're like, Doc, I'm on a treadmill. What am I doing? Here's where the calcineurin inhibitors, sort of the slow and steadies, and then this is where I say, hey, if it's spreading, it's not doing better, biopsy. But probably the number one cause of blood on the toilet, of blood in the genitals, is rough wiping. So I said, please don't use bathroom wipes. They have preservatives in there. Don't use things like Vagisil, tons of allergens. Use your hands in a bar soap. Don't get that mitten or scrubber out that you have. And then air dry. And keep our stool like regular. People are is my stool spreading my perianal skin, and I say, hey, this skin is designed to deal with it. You want it to be well formed, move through, but other than that, no need to micromanage. Um, when I say them, I said, call this the baby test. Would you put it on a baby? If you put it on a baby, you can put it on your genitals. Hands, soap in a bar, yes. Scrubbing mittens, puff, little apricot scrub, rubbing alcohol, they're good. You know, they try to buy into that. And so with that, I will not torment you further, but I just will get to the very end and show some resources that I like. Up to date is great for treatment options. They really list it nicely and they're updated pretty quickly. Visual DX is a photo kind of diagnostic tool. You can throw in a couple of features and they'll spit you out a diagnosis. They're, of course, adding AI, which is very sexy, though unclear how helpful. And and then Dermatology places has really good patient handouts. And with that, I will leave it. And thank you so much.